Good evening, everyone. Welcome again to our mask ultrasound Zoom meeting. It's been a long day for a lot of us, and for some of you here, we've been really expecting Dr. Robert Monaco to be here, and we're so fortunate to have him eventually. And this is really a very important topic, because this is one of the areas in the ultrasound which is also very challenging, because we've got to see both superficial and deep structures in this very area. And a lot of our problems, say back pain and things like that, could also be attributed with some structural lesions or problems in this area. So I'm really thankful that Dr. Robert has agreed to give a part 2 of his lecture on the hamstring. And it's very good that it kind of complements the lecture that we had last night with Dr. Medrick Hall, which is really very nice as well, where he gave us some stages, some grading system, and how we can guide the patients into the return to play. So I just would like to welcome everyone to our meeting again tonight. And with no further introduction, we know already Dr. Robert Monaco. He's been a very active ultrasonologist, doing a lot of lectures and doing a lot of training, both for his residents and anywhere in the world, the US and Europe, and hopefully in Asia soon. And
Yes.
So we would like to welcome you all. Welcome Dr. Robert again. And as we begin, let us just pause for a moment for a while. Let's just have a prayer. Heavenly Father, we thank you for this beautiful day. Thank you, Lord, for life, for strength, for the opportunity, Lord, that we can learn amidst this viral pandemic. We don't know exactly where it would end, but what we know is you have given us the talent, the wisdom that we can do something better in spite of all these challenges. Lord, let us always see the positive side of life and focus on the things that we can contribute to the community and help our patients, our physicians, and be just a contributor for good to our community. We thank you for your grace, and we thank you for Dr. Robert, who agreed to give a lecture tonight. We thank you, oh God, for blessing us today. In Jesus' name we pray. Amen. So Dr. Robert, it's your time now. So welcome again to Mask Ultrasound Zoom. Go ahead.
All right, well, thank you all for having me here on this. And this is a pretty challenging topic. We're going to be talking about the deep gluteal syndrome and using ultrasound to evaluate the deep gluteal space on this. Our goals on this are going to really to talk about the differential diagnosis for deep gluteal syndrome. We're going to review the gross and the ultrasound anatomy of this area. We'll discuss some ultrasound protocols you can follow to try to make sure you're evaluating this entire region. And we're going to review some common guided injection approaches. Posterior hip pain is much less common than anterior or lateral hip pain, but it's an important area to be familiar with and evaluate. Many physicians remain very unfamiliar with this area and uncomfortable with evaluating it due to its complexity. However, we're starting to see a growing body of literature on the topic, and we're going to learn today how ultrasound can assist us both in the diagnosis and in doing guided injections in the region. So what is deep gluteal syndrome? It is a pain and or dysesthesias in the buttocks area, hip or posterior thigh, and or radicular pain due to a non-discogenic sciatic nerve entrapment. So that's a lot to say there, but it's basically pain in this region that we're really focusing on, and there'll be many sources of pain in this region. Multiple pathologies can cause this. It's likely underdiagnosed when we're out there in the clinics. And most people are familiar with, obviously, piriformis syndrome, but that is a small subset of deep gluteal syndrome. And we always want to keep that in mind and not label all buttocks pain piriformis. The clinical history on this is patients will present as hip or buttocks pain. They'll have tenderness in the gluteal and retrotrochanteric region. They'll have often sciatic-like pain, often unilateral and exacerbated with hip rotation. And they'll have very commonly some intolerance to sitting more than 20 minutes They may even have some limping with certain movements and have some night pain as well. There are a host of physical exam tests out there, and the multiple tests really speak to the poor specificity of them. I've listed some here, and they're important to be familiar with on there if you evaluate this region. And it's important to combine the tests together to try to get a better sense of what's going on in this region. Here's a list of just some of the exam tests. And anytime we have this many exam tests, we know it's a challenging area where the physical exam can really be limited in value. And it's also where ultrasound can come in to really bridge that gap where we see limits of our exam to use the imaging technology to help further our evaluation paradigm. When we think of the sources of gluteal pain, think broadly first. Is this pain more spinal based, coming from the lumbar or SI? Is it coming specifically to structures in the region, the external rotators, the hamstring origin, or your glutes? Is there a nerve impingement component, such as a sciatic or one of the other nerves, such as the pudendal? Are there a fascial component, either the myofascia or fibrous bands in the area that may be a problem? Or are we seeing referred pain from the pelvic or urologic area, which can commonly refer to this area, and always needs to be thinking in the back of our mind when we evaluate these areas to make sure nothing else is going on besides the musculoskeletal system. Referred pain is really critical, and to always rule out first before we focus on the structures in this region, which we'll evaluate with sonography. Remember, the sciatic nerve, any irritation from the L4 to S3 can refer pain to this posterior hip region. There may be overlapping issues going on there, and we may get referred pain from urologic or gynecologic. So always keep that in the back of your mind as you go through this to make sure that we're not dealing with something else before we focus on the structural area. So what's the epidemiology like? Well, it's really unclear because we've really lacked definitive tests and definitions of what deep gluteal pain is, or even what piriformis is. Many people call it different things on that. I think we're finally starting to come up with some common terms that we can use, and as we get more detailed with imaging, we're starting to get better at this. But this may be about 5 to 8% of back pain, but it's hard really to tell on that. If we look at some of the surgical literature, of about 500 cases that underwent surgery, about 25% of the time it's piriformis, 75% of the time it's other structures in this region that are causing the pain. So keep that in mind. Piriformis is probably just a subset of deep gluteal syndrome, but we want to be very familiar with it because it's probably at least a quarter of the cases on that. When we talk about the deep gluteal space, we're really talking about a small focal area, which borders include posteriorly the glute max, medially the sacrotuberous ligament, laterally the trochanter, proximally the sciatic notch, and distally the ischial tuberosity. We'll talk about the structures that are fallen here that we want to see on sonography and be able to evaluate on that. Our basic checklist for ultrasound of this region are going to be our deep external rotators, including the piriformis, the Obturator Internus and Gemelli, which really functions as a complex, the quadratus femoris, the sciatic nerve, and a more detailed evaluation of the ischial tuberosity and bursa and hamstring tendon, which we spoke about before. On the advanced side, we want to be familiar with the neurovascular structures of the superior and inferior gluteal neurovascular structures, and the ligaments of the sacrotuberous spinous. The pudendal nerve will occasionally be involved, as well as the posterior femoral cutaneous. So let's review this bony anatomy that we can look at in this region. Because some patients are very large and the structures are deep, we have to be very, very familiar with the contours of the bone to help us know exactly where we're at within this region. We start with the greater sciatic notch, where the piriformis will run through, and then the lesser sciatic notch. The greater and lesser are separated by the sacrospinous ligament here, coming across to the spinous process. And then more medially, the sacrotuberous ligament will be another landmark we will use. Remember this bony contour of the spinous process with the sciatic notch, because as we come down with our probe, we'll see an opening, and then we'll see the spinous process. Also note the hip joint here will be visualized in our sonography, and we'll see a small scope of the posterior aspect of the hip joint, where we'll see the joint with the hyperechoic bone of the ilium, as well as the femoral head, and obviously the trochanter. What does this look like anatomically? Well, we're going to be focusing on this space. Primarily, we're looking at the piriformis, sciatic nerve, the quadratus complex coming in here of the obturator internus, and the quadratus femoris sitting below here. Let's review this anatomy on a cadaver specimen and see. We really want to focus on the piriformis coming out of the sciatic notch, coming down and attaching to the superior aspect of the greater trochanter. Note the angle it takes. The obturator internus is less commonly evaluated. It's more of an anterior structure. We're going to skip that and not focus on it, but we really want to focus on the obturator internus, which is a very, very important muscle. It has a broad muscle belly that sits on the inside of the pelvis, and it will make a 90-degree turn as it goes in towards attaching to the trochanter. Note here the muscle belly, and then note how it turns across the bone and makes a 90-degree turn, the only muscle in the body to turn like this, to come all the way directly across the tracts to the trochanter on that. It has a long tendinous portion, which can get involved in pathology. Superior to it is the gemelli, superior gemelli, and the inferior gemelli, making a complex of the conjoint tendon, with the gemelli originating here and attaching with the obturator to the trochanteric region. Lastly, we look at the quadratus femoris coming across, which is a broad quadrangular muscle with a broad attachment. It acts as a stabilizer of the pelvis with its origin here and attachment here. It's an important landmark, easy to find, and the sciatic nerve will sit on top. The sciatic is very important. As we see, it will run underneath the piriformis in most cases and run down on top of the quadratus femoris. Note the vessels with the sciatic, including the superior gluteal artery and nerve and the inferior gluteal artery sitting back. So note the sciatic here with the piriformis there and the vessels above and below as it runs down. It will run down with the nerve and the vessels, and we'll see this in our large patients, which will be helpful on this. It may be easier to think of this schematically as a clock with the attachments of the muscles to the posterior pelvis sitting here. We can see the piriformis coming in, and we'll see a clock-like formation if we think about this, with the piriformis attaching around the 10 to 11 o'clock, the gemelli around the 8 to 10 o'clock, the quadratus more in the 6 to 7 region, and then on top we see the medius coming in, and then more anteriorly would be the minimus. So thinking of this as a clock as you're working around the whole posterior pelvis can be very helpful when you're isolating these structures down and keeping in your head about where you're at as you rotate around that trochanter. The key structures in this region we like to think about in zones. So we start our evaluation by looking at the proximal aspect of the deep gluteal space, which focuses on the piriformis syndrome. The middle aspect, which focuses on the obturator internus syndrome. The distal aspect, which focuses on the ischiofemoral and hamstring origin tendon syndromes. And then we think about either neurologic structures that can get involved and or the enthesis at the trochanter. Don't label all posterior gluteal pain piriformis. That's an error. We really want to subset what's going on so we can address either rehab or interventional approaches on that. So we'll start with zones as we evaluate this, and we'll start with this proximal zone first as we go through the structures, looking at the ilium, the artery, the piriformis and sciatic. Then we'll follow down to the middle zone and a more distal zone and have different diagnoses in different regions on that. In the superior zone, again, note the artery that we'll look for as we go through this. The piriformis we're familiar with and we just saw will run from its origin all the way through the sciatic notch to its insertion, and again, running along with the artery. So how do we evaluate this sonographically? In thin patients, we can use a linear probe with a wider field of view, but large patients, we need a curvilinear probe. We want to start by finding the ilium and look for either gluteal artery, particularly in our large patients, and use internal external rotation of the leg. It can be very helpful as we evaluate these. We usually do these prone, but they can also be done side-lying. So how does this look? We start with our probe up top. We find the hyperechoic ilium. We work our probe down. As we work it down, we start to get into looking at the artery coming into view here and the sciatic notch. This will be very helpful in our bigger patients. Smaller patients, we can easily see this on that. Once we find the sciatic notch, we'll pivot the probe 30 degrees towards the trochanter to line up over the piriformis in this aspect. The piriformis sits here with its attachment into the trochanter with the sciatic nerve sitting below. We can use motion on this. So as we use motion coming across here, we'll start to see the muscle move, and we can see here the muscle moving well here, sciatic nerve sitting below here, and use your dynamic motion. Note the glutes will not move, but the piriformis will move, and this will help us isolate the piriformis down and give us a better idea on how it moves on that. Note that there may be some variability in the attachments of the piriformis, which we'll talk about, and there may be some variability of the muscle, and sometimes we can see a split muscle, which may possibly contribute to pain on this. So let's go over how I scan this and kind of do a quick demo of this so we can follow this along.
I'll start by evaluating the piriformis muscle. I'll use a curvilinear probe here to get the best views of it. There's a few different ways to start the evaluation. I'm going to start from a proximal to distal by starting with the probe placed in the upper outer quadrant here so I can see the hyperechoic ilium bone. If they're very big, I will turn my Doppler on to help find the superior gluteal artery as it will come into play. I will then follow my probe distally, and we will look for the sciatic notch, and we'll see the large artery that happens with superior gluteal artery. That's also an indication that we're at the sciatic notch. The sciatic nerve will run with that artery. I will shut the Doppler off and go back here. Superior gluteal artery and sciatic notch. And here, once I'm in the notch, I will pivot the probe 30 degrees to line up directly on the piriformis muscle here. We can see the piriformis more easily by having the patient move their leg internally, an external rotation here, and seeing the muscle of the piriformis, and it starts to form its myotendinous junction right where the arrow is at. Note the sciatic nerve location sitting here, and the sciatic can be seen coming out. Most commonly, it comes below the piriformis muscle, but it can come through the piriformis or above. Once I locate the piriformis muscle, I can follow it down to its insertion into the trochanter and the posterior aspect of the trochanter as seen here on that. So once again, piriformis muscle with its orientation to sciatic nerve on that, and we saw earlier the superior gluteal artery on that.
So when we see the piriformis, the first thing we want to think about is if they have pain over it, what are the potential causes of pain in this region? There's 6 things we really want to focus on here. One is hypertrophy of the muscle. There may be anomalous attachments of the tendon. We may see normal tendon problems in this region. We may see dynamic sciatic entrapment from either myofascial or trigger points. There may be an anomalous course of the sciatic, or there may be fascial band compression. I want to briefly talk about each one as you scan this area, what you want to think about of that. So hypertrophy is the first thing you should look for. Here we can see a hypertrophy muscle versus a normal side, but this can be very difficult to distinguish, particularly in large patients, or we don't have high-end equipment on that. Also, this may not be pathognomonic, as MRI will show some asymmetry of the piriformis in asymptomatic patients, so we have to really kind of correlate this clinically on it. But we do think that hypertrophy is associated with sciatic compression. So newer literature is suggesting doing some cross-sectional areas in this area to help diagnose piriformis syndrome. And I think as further papers come out, it may be more valuable on this to see, but more work needs to be done on this. But look for hypertrophy first. The second thing to look for is these accessory tendon variants. Most of the time we think of the piriformis this way, as it attaching directly to the troch, but about 40% or more of the time, it's combined by attaching to the superior gemelli or obturator, or even the glute medius, and kind of forming a combined tendon. So when we think about this, this may be why we get pain in different regions of the buttocks, and some of these tendons might need to be treated as a complex on that. So you need to really think about that. Unfortunately, ultrasound sometimes it's hard to distinguish in large patients whether you have a tendon variant or not, but clinically I think it's important. In a small percentage of cases, we also see it fusing with the glute medius and the anterior approach. And people who have pain directly over that attachment, one should think about the combination tendon variant as we're addressing some of these things from an injection approach. The common tendon problems that we find in other tendons in the body should also be thought about, such as tendinosis, calcifications, avulsions, strains, hematomas, etc. So obviously, take a look at that as well. There is some thought that the sciatic nerve can be caught up in myofascial thickening of the fascia above the piriformis, and we will see this occasionally. So take a look at the myofascia there, look for any fibrosis or thickening of that, and see. Some of these patients will also have some trigger points when you're injecting the area, and there's been some studies showing some success with dry needling and acupuncture techniques on that area. So this may be playing a role. We all know that the majority of the sciatic nerve comes underneath the piriformis in about 80 to 90% of the time. But there can be other variants that we can pick up on either MRI or ultrasound of this. So be aware about that. Some of the studies have shown that the differences in where the sciatic nerve comes out may predispose to pain in this region, though it's not very clear. And some people that have differing anatomy don't have pain. So you have to clinically correlate this. While the majority of the piriformis comes out underneath, the sciatic comes out underneath the piriformis, 14% will have a variation where it comes through the piriformis and underneath, and then we'll see some other variations where we see it coming out either above, or it's split, or just above, or just through. These are much less common, but be aware about at least about looking for it coming through the piriformis. And that's important also when you're doing your injection. If you don't see that sciatic nerve well underneath, be aware that it might be coming through the piriformis, and take a look at that a little bit more thoroughly. We also know that the sciatic runs down underneath the piriformis, and then on top of the quadratus, it sits about 1.5 centimeters laterally to the ischial tuberosity. And we know it's tethered by some bands, particularly at the obturator level on These bands are not well seen with ultrasound, yet with the current technology, they're better seen with MRI, neurography, but these bands probably play a significant role. Some of the newer research out in some of the surgical literature, particularly on endoscopy, shows these bands, and there's different types of band. There's 3 structural types, some with vascular components to it, some are compressive and some are more adhesive, and they're in different locations on that. And these bands have been implicated in pain in this region. So they're important to think about schematically in our concept of pain in this region. Here we can see some of the compressive bands that can press on the sciatic nerve, as well as some of the adhesive bands. And some of these bands also can remain undefined in different areas that we can see that can compress the sciatic nerve. So I think this is really important when we talk about our injection approaches, because we may be seeing some compression of the sciatic by some anomalous bands as a source of pain in this region. These bands can be seen on endoscopy, and they tend to be somewhat vascular at times, and may cause some ischemia to the area. And post-surgically, you can see a lot of scarring in this area too. So if I have patients who are not doing well, we will send them to a colleague of ours for endoscopy and release in this area with surgical techniques on that. But what can you do with ultrasound, and how can we do non-operative care in this region? Well, we want to first think about the piriformis injection on this and understand how to do this, and then talk about what is our target for this injection, because it's not very clear in the literature. Most of the time, our target's either going to be the myofascia, the muscle, the tendon, or the sciatic sitting underneath there. And we have a variety of things we can inject between saline, steroid, Botox, or our biologics on that. So how do we do this injection? I like to go through my setup on how I approach this area.
I prefer injecting the piriformis from a lateral to medial approach in this position here. I'll first find the ilium, sciatic notch, pivot my probe so I can line up over the piriformis muscle coming in and out of the notch. Piriformis muscle. Sciatic nerve noted below the arrow here. Depending on the problem with the patient will depend where we inject the piriformis muscle. Most commonly, we will inject just above it, the piriformis, where the arrow is. On that, sometimes we will dissect that fascia out if it's very thick. We can also inject into the muscle itself on that and do a trigger point, or if the muscle is hypertrophy, or we can inject all 3 of the above and dissect out the sciatic nerve sitting below this region here. The needle will be coming from the right of the screen down to the fascia in the muscle, and then to dissect the sciatic if clinically indicated on that.
So there's not a lot of great literature on piriformis injections. There's some small series where it seems that cortisone helped in about 50% of cases. But again, some of these cases are not really clear what the underlying diagnosis is, and they're just labeled as piriformis. Cortisone with rehab seems to help more people on that. We have very limited data on orthobiologics in this region on that. And there's been some more recent study looking at hydrodissection of the region with some decent results. But again, the diagnosis was not really clear on this, but I would certainly consider this if they have sciatic symptoms in this region that are not coming from the spine, or their EMG is positive. I would certainly consider a hydrodissection approach to this region on that. We're going to turn our attention now to the middle of the deep gluteal space, where we're going to be talking about the Gemelli and Obturator complex, and a little bit about the Pudendal nerve, which can be a source of pain and needs to be thought about because it commonly can be missed. The Gemelli has both superior and inferior muscle on, and it's not reported much in the literature as pathologic. So I really don't try to isolate these structures, but treat the combined structures of the Gemelli with the Obturator Internus as a conjoint tendon as a source of pain, and treat this as a unit on this. They can be individually seen on ultrasound in thin people, but in large people, it's hard to distinguish the Gemelli out. Think of the Obturator Internus as the main structure here. It's a very unique muscle, as we saw, with a 90-degree turn into the pelvis, and it sits in that lesser sciatic notch, so just below the spinous process there that you want to be familiar with on that. The obturator has the tendon portion near where it turns into the pelvis has a bursa, and it comes over a thick fibrocartilage area, which can be a source of pain in some people, as well as a source of bursitis. Remember, the obturator combines with the piriformis in about 46% of cases. So while we may be seeing obturator pain, the piriformis may be connecting and playing a significant role in this. One wants to distinguish, is it more the obturator or the piriformis, and more at the tendons portion, at the troch, or whether it's more as it goes into the pelvis on this. So here's what the obturator looks like as it comes into the pelvis with the sciatic nerve sitting above. And again, using dynamic motion will be very helpful as we look at this obturator, but always look for that 90-degree turn into the pelvis. With motion here, we can see the obturator going in and out of the pelvis to easily identify it, as we used also with the piriformis. Note the hip joint sitting posteriorly here. And again, obturator going in and out. There's a small bursa that sits over here that may be a source of pain, or the sciatic may be a problem here as well. So how do I evaluate this area sonographically? Let's go through a demo.
We're going to turn our attention now to the middle aspect of the posterior external rotators, focusing on the obturator and the superior and inferior gemelli. I'll start here with a linear probe so we get a little bit more detail, but we'll also scan this with the curvilinear probe in most patients. I'm going to start by finding my piriformis as we prior saw. We start upper outer quadrant with the ilium. We come down again till sciatic notch. We pivot our probe till we line up on the piriformis muscle here, as we see. Once I am on piriformis muscle, I am now going to go more distal and follow the bony contour. As I come more distal, you start to see a tendinous structure appear, and that's going to be the superior gemelli. I will then come a little bit more distal, and the probe will flatten out, and you'll start to see a structure coming across the bone, which is again the superior gemelli. And a little bit more distal, we see the obturator internus, which goes deeply into the pelvis. The obturator internus turns around that spine and goes into the pelvis here, as we can see. The obturator internus going into the pelvis on that. If I was to come a little bit more inferior, we start to see the tendon of the inferior gemelli come up. I also want to emphasize one other structure in this region. That's going to be the pudendal nerve. To find that, we go back up just above the obturator until we can see the gemelli. Then we come a little bit more medially, and we look for a structure coming across, and that's going to be the sacrospinous ligament, right, attaching right there. And then we look for the nerve sitting above the sacrospinous ligament next to the artery here, and that would be the pudendal nerve and artery sitting right.
So the Gemelli obturator is important because it can be a source of pathology. Remember, again, that combines with the piriformis, so you may be seeing pain in this region from the whole complex. We know the obturator internus tends to be tethered to the sciatic, so we may also be getting some sciatic sort of pain in this region as well, or it may be coming directly from the obturator tendon. The obturator and the piriformis can make a scissoring-like effect on this sciatic to create some shearing and some pain in this area. In our athletes, they may be subject to tendinopathy or bursopathy, particularly at the 90-degree turn into the pelvis. So be aware of that and look for that on either changes with ultrasound or sonal palpation on that. These will present very similar to the same symptoms of piriformis syndrome, but the pain will be 2 to 3 centimeters more distal over the obturator complex rather than at the sciatic notch over the piriformis on that. An obturator injection may help you distinguish if the pain is coming from the obturator rather than another structure on that. And there's a variety of approaches here. I prefer to take a in-plane long axis approach from a lateral to medial approach for the tendon and the bursa. If I'm just doing the muscle and it's more in the pelvis, I'll do a medial to lateral approach. Again, where you inject is really can be very difficult to determine, whether it's the muscle, the tendon, the bursa, or a volume dissection of the sciatic, and clinical correlation needs to be done. And sometimes we'll combine all these together, as we saw in the piriformis on that. Let's talk a little bit about this approach and how I set it up.
To inject the obturator Gemelli complex, we're going to be coming from a lateral to medial approach. We'll again place our probe, as priorly discussed, to find the obturator turning into the pelvis. Here we see the obturator turning into the pelvis. Depending on the area of sonal palpation where pain is at, we can address the target here, or more commonly, we will likely dissect the sciatic nerve above it if that seems to be causing the pain. So the sciatic is clearly seen above it here, and we would approach from a lateral to medial approach and dissect around the sciatic, or if indicated, direct the muscle or tendon of the obturator complex slightly distal. As seen prior, you can also do your Pudendal injection in this location.
The Pudendal is something to just keep in your mind, though it's not a common source of pain on this. It oftentimes, though, can get mixed for many, many years, and there's certain clinical criteria that you can follow that will help you in identifying it. But be aware about it, particularly if they have pain or numbness focused more to the genital area, and it may cause some symptoms of sexual dysfunction. So it's important to ask the questions if they're getting referred pain to the genital area on that. And that nerve may become entrapped in this region on that. Remember, the nerve is running medial to the artery on that, and can be identified in most patients if you know the anatomy in greater detail. Here's how I take a look at that Pudendal in greater detail.
One of the more uncommon structures we might want to find is the Pudendal artery and nerve, sometimes through a diagnostic injection. We can find them by locating the obturator, which we saw earlier. The obturator is easiest to find as it goes into the pelvis. So here we're lined up on the obturator, and again, we can find it going into the pelvis here. Once that's found, we will then look at the spine for the sacrospinous ligament coming across. Here we can see the sacrospinous ligament coming across, attaching to the spine. Just above the sacrospinous ligament sits the artery and the nerve of the Pudendal artery, and that can be addressed with an injection. Just above the artery and nerve, you're seeing in a transverse plane is the sacrotuberous ligament coming across on that. So obturator, spinous, sacrospinous, artery and nerve, and sacrotuberous above.
So here's schematically the nerve coming out with the sacrospinous here and the sacrotuberous, which sits above here in the schematic here with the sciatic. So sitting very medially, the artery would run with this, with the nerve being more medially with this. It also can get caught up in Alcock's canal here, which can also be injected here and can be a source of entrapment as well. I prefer to do these from higher up approach where you can go either medial to lateral, inject around the nerve as we saw it before between the sacrotuberous and sacrospinous ligaments, but you can also inject it more distally, going from a lateral to medial approach at Alcock's canal. A very good reference done recently out of Canada, which showed some nice schematics of this. Note it's about 81% accurate, so this is a tough area, particularly in large patients. Using your Doppler can be helpful, and really knowing your anatomy will help enhance your injection on that. Lastly, we're going to talk about the distal aspect of it, where we're talking about the quadratus femoris and the hamstring origin, and a little bit about the posterior femoral cutaneous nerve, which can get involved. The quadratus femoris is an important muscle. It acts really to stabilize rather than externally rotate the hip on that. Its origin and insertion we saw before as a quadrangular muscle attaching at the trochanter. The average space between the two is about 23 millimeters, but there's some variability, particularly in female patients. Note the sciatic sitting about 1.2 centimeters lateral and more anteriorly or deeper as we're looking from the posterior approach. The posterior femoral cutaneous nerve is a small nerve that comes off between the sciatic and the tuberosity and runs on top of the tuberosity, and may be involved in hamstring pathology and sometimes pain in this area, and can be a source of pain as well. Most importantly, clinically, is we want to be familiar with the ischiofemoral impingement syndrome. This is where the quadratus femoris may be getting impinged between the two structures, bony structures on that. We may see a decreased space, particularly in some people with hip internal rotation and external rotation. And we may see other factors that may cause problems decreasing the space, such as hamstring tendinosis, ischiotuberosity exostosis, other developmental issues which may cause the space to be narrowed. This is more common in middle-aged women and may be bilateral in nature. An MRI can be very, very helpful in looking at some subtle edema in this area rather than ultrasound, which will be a little bit tougher to see, but ultrasound is key for dynamic imaging of the area. The walking and stride tests are kind of very pathognomonic of ischiofemoral impingement type pain and should be elicited on that. Sonographically, we want to find our landmarks and look for the quadrangular quadratus with the sciatic sitting about 1 centimeter over, with the ischium and the hamstring tendon and the tuberosity. Remember, MRI is better for edema here, but ultrasound for using the dynamics and looking for any sort of pressure effects on the sciatic in this area or impingement of the tendon itself. Let's go over how we evaluate this area.
Our next structure to see is the quadratus femoris to look for ischiofemoral impingement, as well as a good area to pick up the sciatic nerve. We'll also start to see the hamstring attachments attached to the ischium as the quadratus goes between the ischium and the trochanter on that. I'm going to start by placing my probe proximally and working my way down to the ilium, sciatic notch, flatten the probe to look at the Obturator Internus going into the pelvis, then walk down just a bit further. As we walk further, we start to see a quadrangular muscle sitting between the ischium and the ilium. So here we can point out the sciatic nerve sitting right here, and to its right is the ischium with the attachment of the hamstring in cross section and the quadratus. Once we're in this area and we see the quadratus as a quadrangular structure here, we can move our probe and we can look to see that the sciatic nerve rises. We can also evaluate for ischial impingement to see if the ischium comes close to the lesser trochanter, which we're watching here. This is a good way to pick up the sciatic nerve for any aspects as well. In this case, you also can see some branches off the sciatic coming, which is going to be the posterior cutaneous nerve coming off the sciatic, and this will run down over the ischium and can be involved in hamstring problems.
So injections to this area, I prefer an in-plane long axis lateral to medial approach. Again, which location will depend on what you see pathology-wise and clinically, whether you're injecting the muscle itself, doing a sciatic nerve hydrodissection, both, or whether we're just doing a diagnostic injection of the region. Also, if there's hamstring pathology, as prior discussed, we can address that through multiple ways, either with tenotomy, PRP, cortisone, etc., depending on your approach on that. So here's our setup for quadratus injection.
Our last area, the posterior pelvis, is to inject the quadratus femoris. For this approach, we can also do a dissection of the sciatic nerve or do a hamstring injection of the origin. We'll locate again the sciatic and the quadratus in the same fashion. Here we can see the sciatic nerve sitting next to the ischium and the quadratus muscle below it. We'll be taking a lateral approach to this, coming in from a lateral to medial approach on this. If our injection is to the muscle, we inject this approach here directly down to the muscle on that. If we're doing a dissection of the sciatic, we can inject around the sciatic this way. And if we're doing a hamstring, we're going to move the probe more medially and proximally. So we push the sciatic down to the lower aspect on the right of the screen, and we have the tendon of the hamstring where we can inject as sciatic is sitting below it and out of view for what we need to do to the hamstring tendon.
Ischiofemoral impingement, there's very little literature on injection-based treatments. There's some small amount of subsets of literature showing some promising results with cortisone, 2-week outcomes, but doesn't really hold up that well there. It can be very useful as a diagnostic injection as well. Very limited studies on orthobiologics with only some case reports out there in the literature, and more research needs to be done on this area for injection-based therapies. This can be a surgical indication on certain people that have severe ischiofemoral impingement, and correcting the underlying anatomy will help with the underlying process, but it's a fairly large surgery on that. I'm going to sum it up with our full evaluation of the deep gluteal space and how I approach this quickly when I'm in an office setting and we're looking to get a quick area and combine it with what we're seeing clinically on our tests.
So if we were to do this quickly to run through these structures, we'll see here moving the probe down and covering the entire structures on this. I place the probe superiorly, find the ilium, come down till we find sciatic notch, pivot the probe to line up over the piriformis muscle here with sciatic below the arrow, follow it down till we can see the obturator internus go in there with sciatic now sitting in the middle here, and then go slightly distal, following sciatic down till we're into the quadratus femoris muscle here with sciatic here.
So in conclusion, deep gluteal space is deep gluteal syndrome is a complex and very challenging problem to deal with. A structured evaluation with a good clinical history and ultrasound imaging combined with other imaging may help localize pathology to specific regions in the deep gluteal space. Ultrasound is extremely valuable in the diagnostic evaluation and in any interventional techniques in the area. We need to have further research on this area in terms of our injection techniques and what on our inject dates out as we move forward on this. And that about wraps up the talk there, and hopefully we'll have some chance for discussion on some of the key topics of this area.
Thank you, Robert, again for that very comprehensive lecture on the posterior hip and, of course, the dorsal gluteal area. Indeed, it's a very challenging part of the problem that patients are always complaining. Now, I have a question for you. Have you tried using Botox for piriformis?
I have not. I'm starting to work with a colleague of mine that does a lot of Botox, I do think it can have an indication on some of the papers in the that we've seen in this region, but I'm really hesitant because of the proximity to the sciatic, and to be really, really confident and careful in this region. So I've not used it yet in clinical cases on that. I do think it is an option, but I'm more inclined myself to just do a hydrodissection of this region and or sometimes a biologic agent. And I found that those two will give me some decent results on that. And if I don't see that, I tend to look for a more structural based problem with MRI neurography, and think about doing surgical release with a colleague of mine rather than Botox. But I do think that it's intriguing to think about and how Botox might be helpful in this region, particularly if we have a hypertrophic case going on.
Yeah. And of course, another question that's sometimes very hard to settle is patients with perineal pain or crotch pain, maybe secondary to chronic bikes, or for some female patients, for some reasons, they just have some pain right there. Have you tried injecting the pudendal nerve right at the Alcox canal?
Yes, I like to inject it a little bit more proximal. I think it's easier, but I think that injection is a good diagnostic injection to see if it relieves their pain on that. And I think there's probably some value in trying at least a hydrodissection of that region on that. So I think this is something that gets commonly missed by many patients. And I think knowing the anatomy, we can clearly get to the area well. And I think we can help these patients by at least establishing a diagnosis and then seeing if we can get any relief with an injection. And obviously pelvic floor therapy is probably critical on this. But I think if we can establish the diagnosis with a diagnostic injection, hopefully get some relief, I think it's helpful. I've not done as much Alcox canal injections. I think it's easier to find up more proximal on that. On that, though, I think the recent paper would show that you're probably successful in either case. So I'll try proximally injecting it where I think I can see the nerve better. If that didn't work, I'll come back and perhaps do a second injection at Alcox canal if I'm not certain I had enough either appropriate position there, because it is a very challenging injection in many patients.
Right. So any other question from our attendees? Dr. Robert has very comprehensively discussed the posterior portion, which really is a challenging area because of the depth. And at the same time, there are superficial structures that really need to be seen as well. And maybe just before anybody, there's no other question, but let me just ask one more time. Okay, yeah, okay, go ahead, Pash, go ahead. Yeah.
Good morning, Dr. Robert. Thank you so much for doing another lecture with us. I really appreciate every time you do the lecture. It's very comprehensive. So my question is, you mentioned earlier that we can use orthobiologics when doing hydrodissection. So when there are sciatic nerve entrapments, when do you actually decide to do orthobiologics, or do you start with using like dextrose first to hydrodissect the area?
Yeah, so I definitely will start with a 5% dextrose solution for doing a hydrodissection for that area first. If I really think the problem is with a sciatic entrapment, and I'll use a fair amount of volume in between 10 to 20 mLs, or until I feel I can get appropriate haloing around the nerve on that. I think in some of these cases, it's hard to know where the nerve is entrapped. So I oftentimes will bring them back for a second injection, or if they got partial relief. So I may start, and most of these I do in a transverse plane, so I'm short axis on the nerve. So we're not really covering the entire posterior aspect. So I may do one area, then judge their response and bring them back, and then do a lower area. Also, if I get a partial response from a volume dissection that doesn't hold up, that's when I'll think about using either a platelet poor plasma type of product, or if I think there's something going on in the muscle, I'll do a combination with a PRP, leukocyte poor, and a platelet poor plasma around the nerve, as well as a leukocyte poor into the tendon. So it will vary, but I usually will start with just either cortisone and in the muscle, and then I will do a dissection around the nerve with the dextrose. And then if I get a partial response that doesn't hold, it's then when I start to consider trying to either up the game by either using a biologic with it for the tendon and or around the nerve area on that. But my first injection is almost always a diagnostic with that. So the biologic fits later in my algorithm to add if I've had some partial response. I won't go to it unless I know I had some sort of response.
Thank you, doctor.
Great. Robert, thank you very much for this very interesting lecture. I know you've been busy and there's a lot of challenges right now, but still you find time to give us this very nice lecture tonight. Of course, morning in your place. And so we really look forward again to seeing you soon. And you be safe. Don't expose yourself to the virus. We don't see it anyway.
I really appreciate everything you put this and the learning that's going on, and really enjoyed yesterday's lecture and look forward to the other speakers you bring along and on that. So, and staying involved with your entire community. So thank you again.
Right, thank you so much. And would like to thank also our attendees. I know it's almost 9 o'clock in our place right here, and probably for some of you it's even more different. So we appreciate your coming, and we will make this lecture available in our page in our Mass Ultrasound YouTube channel. And so if you would like to review them, you can subscribe and look at the lecture again and learn and practice and do the scanning, because as you can see, Dr. Robert has given us a very nice way of scanning it, very simple and you can repeat it, you can do it again over and over again until you really see all the structures that he was talking about. So thank you again, Robert, for all this. And
you're more than welcome.
Yeah, and enjoy your day. And hope we can, as you mentioned, we can have some Zoom meetings still in the near future, and looking forward to it.
Thank you again.
Thank you so much, and thank you to everyone.